Going to talk about leukemias. So in hematological malignancies, we have lymphomas, leukemias, and myelomas, and now we talk about leukemias. It's the first. We have two types of leukemias. There is going to be acute leukemia and chronic leukemias. Under acute leukemias, we have acute lymphoblastic leukemia and acute myeloid leukemia. And under chronic leukemia, we have hairy cell leukemia, chronic lymphocytic leukemia, and chronic myeloid leukemia. Important point here is that here, this is a lymphoblastic, okay? And here, L means lymphocytic. Lymphoblast is a precursor cell. It's an immature cell, and this is a mature cell. So it is important to note right here that for acute leukemia, first we're gonna have immature cells, and it is going to be, because it's acute, it is going to be in young patients, or you could literally say children. And for chronic leukemia, we're gonna have more mature cells, and it is the patients are going to be adults. Okay, now we talk about acute lymphoblastic leukemia. So it is a neoplastic accumulation of lymphoblasts. It is more than 20% in bone marrow, then we call it ALL. It is characterized by positive TDD test, and the TDD is basically a DNA polymerase. But important that it is only raised in case of ALL because TDD is negative in both myeloid cells and mature lymphocytes. So highly specific for ALL. Now, where is the problem? If you look at right here, it is a lymphoblastic. So a lymphoblast right here, this is increasing in number. Everything else will get crowded out. Nothing else will be formed. Only lymphoblasts are going to be formed. Okay, so when there's, what are lymphoblasts? Lymphoblast has no granules, it has high NC ratio and scanty cytoplasm. It can metastasize throughout the body, and it crowd out other hematopoiesis. So it causes thrombocytopenia, decreased platelet, that is, decreased RBCs causing anemia, and neutropenia, decreases neutrophils. But labs is going to show increased WBC count because on CBC, this is misleading. It shows high WBC count because of presence of a lot of lymphoblasts. That is why. Some etiology is radiation exposure. Chemicals like benzene, Down syndrome is very important association in ALL. It could be Turner or Klinefelter as well. Now for pathogenesis, we have two types. We have BALL and TALL. I call it ball and tall. It's just, based on the cell surface markers. Okay, so BALL is having an abnormality in PAX5 gene mutation, and mostly hyperdiploidy occurs, and a chromosome may become more than 50, right? But it's unimportant information. Let's move on. Now we divide the cytogenic abnormalities on the basis of prognosis. In case of ball, it is good prognosis or bad prognosis. In case of good prognosis, we have T translocation 1221, and the bad prognosis is the Philadelphia chromosome 922. I will explain it later in the video when I talk about CML. In case of cytogenetic abnormalities in tall, we have notch gene mutations. Cell markers in case of BALL, we have CD10, 19, and 20. And in case of tall, we have CD2 to 8, but not 10. For ball, chemotherapy has an excellent response, but we also need to do for scrotum and CSF. And chemotherapy is usually done also in tall. Age range in ball is 2 to 5 years old, very young patients. And for tall, it's 13 to 17 years old. The clinical presentation for tall is important because it usually presents with a mediastinal thymic mass, which is called as acute lymphoblastic lymphoma. So right here, what does this mean? What is lymphoma? I told you, you said that lymphomas are different than leukemias. The thing is that when this forms a mass, then it is called as a lymphoma, right? So there is a lot of overlapping between the classifications, and you will also see that in the following videos that I make. In tall, there's also testes involvement and neurological symptoms, but all of these things, these are manifested more in ALL versus AML. Acute myeloid leukemia, as I'm going to tell you a bit further in this video, are also going to have these symptoms, but these are going to be more prominent in ALL. How do you make a diagnosis? So you will look at the peripheral blood smear and find lymphoblast. You look at a blood CBC, you find normocytic or macrocytic anemia, and you can find thrombocytopenia and increased WBCs. This is increased WBCs. You do cytogenetic studies, as I've already told you before. The cell markers I've already told you. And then cytochemical analysis, you do PAS, TDD, and esterase. And of course, you do a bone marrow biopsy and you see hypercellular blast more than 20%. Next, we have acute myeloid leukemia. In acute myeloid leukemia, it is the increased proliferation of myeloid cells. So I go back to my slide of hematopoiesis. Now you see right here is that there is a problem in myeloid. These cells are going to increase and other cells, they are going to decrease. So increased myeloid precursor cells, or we call them myeloblasts, they are going to increase. So the myeloblasts, they are more than 20% than in the bone marrow, and they are MPO, myeloperoxidase positive. And these crystal aggregates of myeloperoxidase are known as the overrods that you can see in pathoslides. Pathohistoslides. The myeloblasts are large, they are immature, they are granular, they have more cytoplasm, they have overrods, and MPO positive. What are the risk factors of AML? They can be caused because of antineoplastic agents. There could be alkylating agents, ionizing agents, benzene, again, Down syndrome, Turner or Klinefelter. But some cause like myelodysplastic syndrome, aplastic anemia, or myeloproliferative disorders can lead to secondary AML, which this acute myeloid leukemia is basically after this. Any kind of acute myeloid leukemia that occurs after these conditions will be called a secondary acute myeloid leukemia. The age range is 40 to 60 years old. That's important because for ALL it was very young patients, right? And for age range for acute myeloid leukemia is 40 to 60 years old. Now for myeloids, it is of course going to crowd out the hematopoiesis, so we're going to have pancytopenia, and there's going to be leukostasis because myeloids is then going to enter the blood, and then of course it is going to stain blood and cause leukostasis, and painless lymphoadenopathy will occur. Now classification is a lot, but good news, we only need to do 3, so there are like 7 like Mission Impossible movies but we only do 3. So the first is acute promyelocytic leukemia. In this, the pathogenesis is T15:17. Now I explain the Philadelphia. This is not Philadelphia. I'm sorry. This is 1517. That is a retinoic acid receptor. It is translocated from 17 to 15, and that receptor, it is going to block the maturation of promyelocytes, and it is going to increase myeloblasts. Now because these myelocytes contains granules, it is going to increase the risk for DIC. And what do you give for treatment is all trans retinoic acid. For acute monocytic leukemia, we have increased monoblasts. Now, monoblasts are less granular, it has speculated cytoplasm, and it has prominent nucleoli, and it is negative for MPO. And it is important for gum infiltration, it has association with mouth. Then last, we have acute megakaryoblast leukemia. It is going to have increased megakaryoplasts, and it is again also negative for MPO. It is associated with marrow fibrosis and associated with Down syndrome. This is the most highly associated form of AML that is associated with Down syndrome. And that is it.